So I'm talking about lateral meniscus repair, avoiding popliteal tendon. How to avoid that, okay? So look at the anatomy of the medial side and lateral side, okay? Again, so the medial side is the bigger, and you see that there's no vital structures around medial side. Lateral side, you see that it's mobile comparing to the medial side, and also you see that this area is a popliteal hiatus, and behind that there's a vessels here, okay? So on the lateral structures, I think for me, I have to be very careful when dealing with the lateral side injury, okay? So what is your main concern during lateral meniscus repair using all inside technique for the lateral meniscus, okay, comparing to the medial? So we have 5 poles: popliteal tendon, popliteal artery, peroneal nerve, tight that compartment, or no concerns. Okay, number B is the most. You are concerning about popliteal artery injury, okay? And the second one is the popliteal tendon. This is the articles. They studying about the lateral meniscus proximities to the neurovascular structures. We found that if you do the lateral meniscus, especially close to the root, about 5 to 10 millimeters, it's very close to the vessel. So this study was in children. They found that it's about 2 millimeters from the lateral root. And if you repair at the body close to the popliteus, yeah, you're very close to the peroneal nerve. So these are two structures that you have to be careful, and also the popliteal tendon. So this is our study. Now we found that the area that is very risky is the area that close to the root, about 5 to 10 millimeters. If you make all inside from the same portal, okay, you are very close to the popliteal artery, okay. It's only 3.7 millimeters. So if you repair the meniscus close to the popliteal tendon from opposite side, that is very close to the popliteal tendon and also the peroneal nerve. So this is a study, very nice study from Dr. Teo, Malaysia. She did a very nice study about the uh, proximity of popliteal artery when you repair the process horn of the lateral meniscus. Yeah. So same finding, she found that 5 to 10 millimeters from the posterior root, you have to be very careful. It's close to the popliteal artery. In contrast, if you repair the meniscus on the medial side, you have no chance to injure the vascular or nerve structure. So this is the first case, 44 years old Thai male. He was tackled by another player on the football field 2 months and has off and on locking and instability. So his examination revealed fixed flexion deformity 10 degree, Lachman positive, and McMurray test positive on the lateral side. From the MRI, you can see that the patient have like double meniscus, double anterior horn side, and meniscus is locked in the notch. So that is the arthroscopic view. She had the bucket handles, yeah, on the lateral side, like that. So this is about 2 months. So the poll questions: which technique would you use to repair this meniscus tear? Inside out, outside in, or all inside repair? Okay, most of you 76% all inside repair. We prefer to do all inside in the back, inside out at the body, and outside in at the anterior. So this patient, I perform the all inside repair. At that time, we didn't have the novel stitch. Okay, I show you. First, I do the meniscus shaving and use the trephination, the KY, to stimulate the bleeding. So we have the mini first pass. Actually, it's just quite nice. Use a meniscus rest. Okay. So for the lateral side, I prefer to use the all inside. If I can avoid the fast fix, that should be fine because this area is very close to the vessels. So I use the mini first pass. So the first stitch I use the central portal, but the second portal I need to come from the lateral. Okay, but the problem is the soft tissue, you need to reload the suture 2 times, right? So the problem is when you try to reload the second one, you see the fat tissue is getting in and stuck. So that's the problem and really struggle. I spent about 10 minutes to solve this problem. Okay, and finally we can solve it, but it's not, we spend a lot of time because of the fat tissue that obstruct the view, because we need to reload 2 times, right? And finally we can repair the meniscus using the all inside technique. That is the mini first pass. And another problem the mini first pass is that it's too bulky. You see that when we get in and you can damage, you see the cartilage, I do some cartilage damage. Okay, even my fellows try to open the joint, but sometimes it's not designed to repair the meniscus. That's why sometimes you can damage the cartilage. Okay, but finally it's nice, but take me 1.5 hours to repair these 3 stitches. Okay, and I have some cartilage damage. So there's some articles mentioned about the popliteal problem when you're dealing with the lateral meniscus. So this article mentioned that if you try to repair the meniscus to the popliteal, the problem is that you lost the physiologic motion of the lateral meniscus. Okay, and over time the suture anchor may lose and may cause the problem. Okay, and you change the mechanics of the lateral side meniscus because you fix the meniscus to the popliteal. This is another study from Bertrand. Bertrand, he did 250 cases of lateral meniscus repair to the popliteal. He said that it's no issue. But anyway, we didn't have the long-term studies about the lateral meniscus repair to the popliteal because I think it should be some um, change of the biomechanics of the lateral side. So this is another patient, same like the previous one. Okay, she had the bucket handle of lateral meniscus. Okay, so the tear is extend from posterior to the body. Okay, so first I did the trephination and I tried to repair the posterior at that time using the fast fix. Okay, and you see that after the fast fix repair, we have some deformities of the meniscus. And then I use the novel stitch close to the popliteal tendon area. Okay, it's very fast and very easy comparing to the first case. Okay, we can use the half pipe to guide the novel stitch into the lateral compartment. So we use the 2 stitch for this the body repair. Okay, I use the simple sliding knot. I make it about 4 to 5 throws. Okay, and then repair the posterior horn again with the fast fix. Okay, so very stable and the patient's quite happy. So post-op protocol for me, I encourage the patient for bucket handles or posterior horn tear. Immobilize the patient in full extension, quadricep exercise, isometric exercise of the quadricep. Immobilize the patient for 2 weeks in full extensions to mold the repair. Protect weight bearing for 6 weeks. Okay, and gradual range of motion 0 to 90. Okay, so in summary, all inside posterior lateral meniscus repair, beware of the neurovascular injury, popliteal tendon. I think for me, no anchor or inside technique are very safe for the lateral side. Okay, and I try to repair the meniscus using the way we call close the zip. We starting from the rim, okay, and proper rehabilitation protocol, okay, and don't give up when you dealing with the meniscus tear. Save the meniscus. Thank you, Sachin.
Thank you, Bancha.